Hi, good afternoon. Thank you for joining us for this month's QTECH meeting. We'll get started in just a few more minutes. Thank you. Hello, good afternoon. Thank you for joining us for this afternoon's QTECH meeting. We're going to get started in just a few more minutes. Thank you. Hello, good afternoon. Thank you for joining us for today's QTECH committee meeting. We are actually just a couple seconds after the top of the hour, so we do have quite a few items we want to cover with everyone. So we're going to go ahead and get started for today's presentation. So welcome. Here we can have all of our health centers listed that are participating. We'll review the agenda very briefly. So welcome to this afternoon's meeting. We're happy to have you for our monthly QTECH committee meeting. So thank you for joining us today. We have quite a few items related to SMBP education in relation to American Heart Month, which then we will transition to a health center spotlight. We have Dr. Lawrence from Jesse Trice Community Health Systems with us this afternoon to tell us a little bit more about a project they implemented for SMBP, as well as hearing from our US team in reference to CGM practical tips for clinics and patients. From there, we'll talk about research and QI with our in-house director of research, Dr. Catherine Chung. And then we may have opportunities as well to hear from Haru Kasai, who will tell us a little bit more about the UDS specification review for both 2020 and 2021. And then from there, we will wrap up our presentation today with some insights from our annual strategic planning results, as well as looking into some other key items and updates. So for today's first segment of the agenda, we're going to have a little conversation in reference to SMBP. So let me go ahead and share my webcam so you all can see. So here we're going to do some rapid fire polling. So our intention this afternoon is we're going to ask everybody a couple questions through the GoToWebinar platform. So from here, we're going to have some couple questions related to self-monitored blood pressure programming at the health center. So this is really the start of our polling with number 1 in reference to, does your health center have an SMBP program? So the options here include yes, no, or unsure. So we'll give everyone just a couple minutes to participate in the polling this afternoon. Okay, why don't we go ahead and take a look at the results that we have so far for poll question number 1.
Oh, I'm sorry. I don't know why the screen isn't showing.
It's okay,
Oh.
No worries. So here we can see the results perfectly. Thank you, Diana, so much for your help on this. So
Welcome.
here we can see that about 53% of health centers are unsure if they have a current program, while 47% had shared that they do not currently have a self-monitored blood pressure program. So thank you for participating. Let's go ahead and jump to the next poll question we have today. Perfect. So the second poll question we have today is in reference to if your health center is using a separate tool or solution to monitor patient self-monitored blood pressure values. Let's go ahead and launch the poll. So here we're asking does your health center use a separate tool to monitor patient self-monitored blood pressure values? So the options are the same here, either yes, no, or unsure. So we'll give everyone a few seconds to participate in today's poll. Okay, so let's maybe give it a couple more seconds. How are we looking? Here we go. So perfect. Thank you so much, Diana, for sharing. The majority of our health centers currently do not use a separate tool to monitor patient self-monitored blood pressure values, which that's totally okay. That's exactly why we invited Dr. Lawrence to help share her insights of how they've implemented a self-monitored blood pressure program and tools to help support their efforts on that end. Let's go ahead and do our last rapid fire polling question for this segment. So here for polling question number 3, we wanted to ask if your health center has a process to ensure that patients are using an AMA validated SMBP device. So as some of you are aware, there is a website that the AMA has published, validatebp.org, and that's a resource that has been promoted as an opportunity for clinics to be informed on the different sort of tools or devices related to SMBP that could be used that are considered validated. So I'll give it just a few seconds. Okay, let's go ahead and take a look. Okay, perfect. Thank you so much, Diana. So it looks like a majority of health centers do not have a process to ensure patients are using an AMA validated SMBP device. That's actually really great insight for us because we've had a lot of conversation in terms of how do we get the blood pressure cuffs to patients and try to formalize the process in terms of making sure that they're validated, but that patients have access as well to the cuffs that they need to help provide those values. So this was really great insight. Thank you so much for sharing. So let's go ahead and advance to our last slide here. Perfect. So here are just some key resources related to self-monitored blood pressure. There was a communication that had been sent out across the network in reference to some information on the AMA website that I mentioned earlier, so that validatebp.org that lists all of the different validated devices that are out there in the space. In addition to that, we did reference 2 resources that are app-based tools or devices that could be used to support a self-monitored blood pressure program. So just keep a lookout on those. We have some links that are within the PowerPoint presentation for you to look at your leisure in reference to how you can actually go about implementing the program as well. As we did that quick polling, we identified that that's definitely an opportunity. So we want to share some resources with you all so that you have the tools necessary to get the program going if that's something your health center is definitely interested in pursuing. So thank you so much for sharing that insight. With that, I think it's a great time to transition to our health center spotlight for this afternoon. So I would like to pass it to Dr. Lawrence, who is the Chief Medical Officer at Jessie Trice Community Health System, and is going to teach us a little bit about Smart UNZ and how she's used that tool in her practice. So thank you so much for joining us this afternoon. Thank you. And I think you might be on mute or double muted, if I'm not mistaken. Okay. Hi. Yes, we can hear you perfectly. Thank you so much for joining.
All right. Thank you very much for having me. I've been with Jessie Trice for about 5 years, so looking forward to being able to speak with you all today. Just to give you a little bit of background information about Jessie Trice, we've been open for about 53 years with experience in delivering healthcare services. We were the first FQHC in the state of Florida and 5th in the nation to provide care to a culturally diverse population, as many of you do. And we have a mission to improve quality of life and to achieve health equity. Today, we operate in 14 comprehensive primary care sites. We also have included a residential substance use disorder facility for women, 40 school-based health sites, 1 university, and a women's shelter for those that are impacted by domestic violence. Next, we annually, we cater to over 45,000 patients, and consistent with national data, about half of all patients, or 47% for Jessie Trice, of our patients with hypertension are uncontrolled. Prior to the COVID-19 pandemic, 64% of Jessie Trice patients with diagnosed hypertension were controlled. But you can see on the next slide that since January of 2020, we've seen monthly decreases in our number of patients with controlled hypertension. Our last report, we were at 43%. So the reasons for this decrease, we believe, are multifactorial, partly because of loss of income. A lot of our patients lost jobs during the pandemic. And with loss of income came a decrease to certain foods, healthy foods. And those things, coupled with other factors such as the lack of the knowledge base about their chronic conditions, as well as knowledge about their medications, compounded the situation as well. And the pandemic itself made it difficult for patients to feel safe in attending regular office visits. And then, of course, there was the digital divide where we had to pivot to telehealth, and our patients just did not have the means necessarily to connect. So as a result, we saw decreases in compliance, not only with hypertension, but diabetes as well, and even in medication compliance with statins. Fortunately for us, with aspirin, that was able to remain steady. So in looking at our roadmap for blood pressure control and statin use, we chose the following goals of achieving greater than 15% of an improvement in blood pressure for African Americans, or greater than a 10% reduction in the systolic blood pressure. We also chose to have greater than a 10% improvement or greater than 80% in statin use. And to accomplish these goals, we selected certain indicators such as increasing touch points with our patients, using care gap reports, and increasing patient engagement. Next, in setting out to address the roadmap and increasing medication intensification or optimizing therapy, it was a great thing in that we had patients who would bring in logs during their visits And we know that many patients will monitor their conditions at home when they have the means to do so. Those with blood pressure devices or glucometers would gladly bring in their logs. We noted that there are available platforms which make it possible for patients to send their data to providers electronically from their devices that have Bluetooth capability. For example, certain blood pressure devices and the continuous glucose monitors could be emailed by patients to their providers. So we know that sometimes written logs pose an issue. They're not always legible. And then we thought about, our patients, so what about those that have 2 or more chronic conditions that require monitoring? Do we want them having to log into 2 separate platforms on a daily basis, and would they even be willing to do that? And then are the patients savvy enough to transmit the data? And then we thought, what about patients who already have devices, but those devices don't have the Bluetooth capability, and thus no platform to deliver the data? And then there was also an issue of HIPAA compliance centered around that. Next slide. So we set about to identify ways to address these concerns while keeping in mind what the evidence shows us. And that's one, that we know that text messaging has been identified as an effective tool to set reminders. And also we know that self-monitoring blood pressure programs have proven to be effective as well. So with these 2 key indicators, we felt that optimizing therapy through remote monitoring and patient-compiled data. We also felt that we could address increasing touch points with our patients by adding in virtual small groups and telehealth and providing those virtual check-ins. 3, we wanted to improve medication adherence. So we thought that by compiling lists of patients on statins, including our diabetic patients in their last visits, that we'd be able to address those parameters as well. And then the 4th parameter was in promoting effective patient engagement and providing incentives, such as giving them the blood pressure devices and also the A1C home test kit. So with the help of a designated nurse practitioner, she helped us to enroll patients into programs. We did have some success with our small groups, but now we wanted to do something on a larger scale. And on the next slide, we decided on a platform called SmartViewMD. What that is a consolidated web-based portal for medical providers to review, monitor, and receive automated alerts of patient vitals shared via patient smartphones from selected third-party medical devices. So for example, blood pressure monitors, glucose. What this platform also did was incorporated pulse oximeters and self-monitoring blood glucose meters and peak flow meters. So, but for the purpose of today's presentation, we'll concentrate on the blood pressure. So the way this works, the patient collects the data through their device. They may enter their results of their blood pressure readings in one of 3 ways. One would be directly from their desktop. The other would be from a phone app, which is downloaded to their phone. And the third one is also the use of their phone, where if they don't send in any data, they would receive a text message reminder asking for their data. And from there, they could type it in and have it sent in. So it's a very simple platform on the next slide. And you see the part that I really like and thought was pretty cool was that we could download the app, which has our Jesse Trice logo on it. So the patient could access this directly from their phone. And we anticipate that this will probably be the most commonly used method. Right now we're in pilot phase. We have about 50 patients enrolled in the program. And that indeed is the way that they're entering the information. And on the next slide, just to give you a closer look, I wanted to show you this brief video. about how to launch the SmartView application.
Hello, my name is Isabel, CMO of Bell IT, and I'm excited to be here with you for the first time and set up our brand new mobile web application, SmartView MD. This application will be offered for both Android and iOS devices. Today I will be showing you the setup process for the iOS platform. I will be guiding you in the step-by-step process and how to install the app shortcut to your home screen and how to set up a new account. First, you will want to go to smartviewmd.com. Next, you will see an icon at the top right corner of your screen with 3 lines. You'll click that and select Sign Up. From there, we'll start off with how to add this application to your home screen. You will click the middle icon at the bottom of your screen and scroll down till you see Add to Home Screen. You will click that. You can name the application whatever you would like, but today I'm going to stick with smartviewmd.com and I'm going to click Add at the top right corner, and it will simply add it to my home screen for easy access. Next, I'll be showing you how to sign up with a new account. You may tap this newly added application on the home screen, and I will be clicking Sign Up at the bottom right. From there, we'll type in our first name, our last name, and our email address. Next, you'll be prompted to enter a strong password with more than 7 characters that consists of a combination of uppercase and lowercase letters, numbers, and special symbols such as punctuation. And once you have entered in each field, you'll click Sign Up. After setting up your account, you are then prompted to select which medical device you are using. The current choices are the continuous glucose monitor, the blood glucose meter, the peak flow meter, the blood pressure monitor, and the fingertip pulse oximeter. After selecting at least one medical device, you may then scroll down to enter your date of birth, gender, weight, height, address, city, state, zip code, phone number, and you may then select your primary health care provider from the drop-down menu. At the bottom of your screen, you have the option to upload a personal photo of yourself if you would like, and then submit your profile. Whenever you have new readings on whichever device or devices you chose, you may then enter them into the next screen. After submitting your readings, you will then be directed to a page with a documented list of the readings you have submitted. I hope this tutorial was useful to you, and thank you for using SmartView MD.
All right, thank you. And then on the next slide, looking at the notification system, I have another brief video for you.
Hello, my name is Isabel, the Chief Marketing Officer of Bell IT. This video is a follow-up on how to install the SmartView MD app on the iOS platform for smartphones. But in this short video, I'm going to be showing you how SmartView MD will remind patients to enter readings daily from their medical devices. When SmartView MD realizes that a patient has not entered a medical device reading in the last 24 hours, it will send a reminder notification to their phone. The reminder notification will include a message like this. Hi, please remember to enter your medical device readings daily in my.smartviewmd.com app. Thank you. When the patient clicks on the link in that message, they will be directed to the SmartView MD app where they can log in and then enter their readings, just as I had shown in my previous video. In my next video, I'll show you how a medical provider will receive and review patient readings for that week from our SmartView MD app and seamlessly attach those readings into the patient's medical report, aka the electronic health record, or more commonly referred to as the medical office's EHR system. Thank you and take care.
Okay. And the same way that it sends text messages, it will send medication reminders asking specifically whether the patient has taken their medication, including their statin or aspirin. And if the patient has not entered any data, again, a reminder is sent asking them to enter their values. And the text will take them directly into the platform for entry. All right, on the next slide, from the provider view, the provider will receive tasks in their inbox through secure messaging. And after opening the task, they will find that the report that includes the data, date, time of entry, the device used, and the provider name. On the next slide, you will see that the info may then be saved to the patient's chart and viewed for later use. For today, we saved this information in a section that we had titled Target BP, but our clinical informatics director, Ms. Herron, actually has created a SmartView MD window to make it easier for providers to identify this data. And on the next slide, the system also will send you average blood pressure readings as well as graphs. They give average 7-day readings, actually. So the other thing is that providers can log directly onto the SmartView MD website to review aggregated patient data. So as I mentioned before, we're in piloting mode. We have 50 patients enrolled. And what I especially like about this is that a rep comes on site who will assist the patients with downloading the app onto their phone and give them instructions on how to use it and make sure that they know how to use it before they leave the clinic. And I have to say that this has proved useful not only for us as providers, but it's proved useful for them as well. Because of their hands-on approach, they noted a few things that they are currently adjusting within their platform. Just to give you an example, some of our patients have vision problems. And so what they've done is to now give the patient an option of enlarging the text, making it easier for them to read. They've also made note, they took inventory of the types of phones that our patients have, and not as a surprise, but most of the patients have Android phones and not so many iPhones. And the other thing that they noted that they wanted to do was to make adjustments for our colorblind patients as well. And then next, the other thing that our patients are now able to do are to be able to transmit results, not with them having to enter results manually, but from their website. A patient, once they take their blood pressure, this reading actually goes automatically. So that negates the need for a patient to have to enter in any data. So I think that actually proves the most easy for a patient to do. They are still implementing this process, but right now it actually does work from the website. And next it will be able to work directly from the Android phone. So for now, this is the system that we are using, and we're hoping to see some improvements in our performance measures.
Thank you, Dr. Lawrence, for that. We do have some questions in the chat. Francis Capitici is asking, does the SmartView app count for UDS or considered self-reported and so not entered into the EHR?
Right. So even for billing purposes, a lot of the reimbursement is not granted unless the info is transmitted directly into the EHR. I do think that recently Medicare and for certain for the HEDIS measure, it is allowed. So what we have to do for now, because it goes through secure messaging and we have to affiliate it with the chart, our nurse practitioner who's assigned to the project will take the average blood pressure reading and enter it into the vital section. So that should allow for the reimbursement part of it. Does that answer your question?
I believe it does. I don't see any other questions in the chat right now. Let me pass it over to Stephanie Smith.
Perfect. Thank you so much, Dr. Lawrence, for taking the time to share your story with everyone. I think as the poll results show, a lot of health centers are still trying to find their way in terms of how they can implement a tool such as this. So thank you for taking the time to share this.
All right, thank you.
Perfect. So then we'll be monitoring the chat for any other sort of questions that may be coming through. But with that, I will Then pass it to our next speaker on today's agenda from UF, Eleni Sheehan.
Hello, thank you so much for inviting me and having me here. I am with the University of Florida and the ECHO Diabetes team. I'm a family nurse practitioner, certified diabetes care and education specialist. I've worked at adult endocrinology clinic at UF for about 5 years, and then in the pediatric endocrinology clinic here for a little over a year now. So I am very happy to talk to you about continuous glucose monitoring and practical tips for you all to implement it into your practice. So just objectives, cite evidence supporting CGM use in diabetes care, how to access patient education resources, address common barriers to patient utilization of CGM, and identify the CPT codes for training and data interpretation. So when thinking about implementing CGM or use in your clinic, you might be thinking, so what is it? How does it work? How can it benefit my patients? What do I need to know about it before I prescribe it? What do my patients need to know about it before they use it? How do the providers see the patient data? And can we bill for this? And if so, how? So we will start with what is continuous glucose monitoring, also called CGM. So basically, it's a system that consists of 3 parts. So there is a sensor, it's a thin wire that is inserted under the skin. The needle does not stay under the patient's skin. The wire goes in, the needle comes. Then there's a device taped over the skin called the transmitter, and that sends data to the receiver, which is a handheld device. So what does it do? It monitors the glucose level of the interstitial fluid every 1 to 5 minutes. The receiver shows not only the glucose level, but also what direction it's going, up, down, sideways. And then some of the systems provide alerts for when the glucose levels are out of the patient's target range. One of the most useful aspects of CGM technology is that it really allows you to see the bigger picture, and it allows your patients to see the bigger picture and trends. So with the blood glucose meter, for example, you see just 1 point in time what that glucose level is, but with the CGM, you can really connect the dots and see what's happening during those in-between times. There is lots of evidence on benefits of using CGM. One large study showed that use of CGM it equates with lower A1C, regardless of what type of insulin delivery they use, whether it's injection or a pump. Next slide. And so just a summary of some of the evidence that's out there shows improved outcomes include reduction in A1C, increased time in range, decreased hypoglycemia, improvement in quality of life, improved sleep, decreased fear of hypoglycemia, anxiety and stress, and more and more evidence is showing that it can be useful as a behavior modification tool for lifestyle change. So when is it appropriate for my patient? Well, the American Diabetes Association's Standard of Medical Care in Diabetes recommends use for adults with type 1 diabetes who aren't meeting glycemic targets, have hypoglycemia unawareness, or also have episodes of hypoglycemia. For adults with type 2 diabetes treated with insulin, not meeting glycemic targets, and for all children and adolescents with type 1. And for patients with all types of diabetes and all ages, those who use insulin, who have an aversion to finger sticks, fear of hypoglycemia, anybody who wants a CGM, athletes, or those who have high levels of physical activity, pregnancy, pre-pregnancy, or folks with communication issues such as being nonverbal or perhaps a young child. So there are 4 systems on the market right now. The Eversense is an implantable CGM. It's cumbersome, requires a lot of training and a procedure every 3 months to implant this device. It's not very popular. Medtronic Guardian is cumbersome and a little clunky to use, not very popular. So today's talk is going to focus on the Dexcom G6 and also on the Abbott Freestyle Libre. Next slide. So this is a really long, busy slide. So I'll try to summarize and point out the differences between these systems. The main difference is that the Freestyle Libre systems are what are called intermittent scan CGM or flash CGM. Basically, you don't know what your glucose level is until you hold a reader up to the transmitter and it shows you what the number is. Whereas Dexcom is a real-time CGM and that it pushes that data to the receiver continuously. None of them require finger sticks. Libre, the sensor life is 14 days, so every 14 days you take it off and replace it. Dexcom is every 10 days. Libre, the transmitter and the sensor are built into one little system, but with the Dexcom, it's separate. So there's 3 components to the Dexcom and 2 to the Libre. The Freestyle Libre 2 is a newer system that has the option to have alerts. The Freestyle of out of range glucose levels, 14-day system does not have that. And then the Dexcom does have those alerts. And Dexcom FDA approved for ages 2 and up, Freestyle Libre 2 ages 4 and up, and 14 ages 18 and up. And we're going to talk about insurance coverage. Next slide, please. So commercial plans, most commercial cover both of these systems. To prescribe it, fairly simple. You can send a prescription to the retail pharmacy. The initial time you prescribe it, you need to send it for 2 parts. The reader, even if they want to use the phone app, they still should have a reader for backup. And then the 14-day sensor, either the 14-day, or the Libre 2 sensor. So because each one lasts for 14 days, you'll need 2 for 1 month supply or 6 for a 90-day supply. Lots of resources on their website on how to do this. So next slide. For Dexcom, it's essentially the same. Most commercial plans process Dexcom as a pharmacy benefit, but some insurance plans process it as durable equipment. So you can send the prescription to the pharmacy. If they say no, likely it needs to go to durable medical equipment. But one option that Dexcom has partnered with Aspen pharmacies. And you can just send the prescription to them. Aspen Pharmacy will follow up with the patient and they will then send the coordinate fulfillment for that prescription at the pharmacy of the patient's choice. When you send a prescription for Dexcom, the initial time it needs to be for 3 components: a receiver, which is once a year, a transmitter, which is needs to be replaced every 90 days, and then the sensor. Remember, these sensors last only 10 days, so you'll need 3 per month or 9 for a 90-day supply. Next slide, please. So Medicare makes it a little more complicated. The criteria that your patient must meet in order for them to provide coverage, and they process everything as durable medical equipment, meaning that you can't prescription to a retail pharmacy, it will be declined and they'll say it's not covered. Actually, it is covered most likely, but it just needs to go to a durable medical equipment supplier. So the criteria are: person with diabetes, they have been using a blood glucose monitor and checking more times a day. What this doesn't say is actually they want to know that it's been done for the past 2 months. They're treated with insulin, 3 or more injections per day, or an insulin. Their insulin treatment regimen requires frequent adjustment on the basis of glucose readings, must have been seen by the prescribing provider within the 6 months, and follow up 6 months after GM. There was published back, I think in April, that due to COVID, some of these requirements were lifted, including the one about being seen in person every 6 months or within 6 months. However, in practice, it seems that the criteria is still in place most of the time. So over on the right-hand column where it says required chart documentation, in order for Medicare to cover this, they're going to ask for a certificate of medical necessity, copy of our notes, plus the prescription. So in your notes, it has to be documented that these folks met the coverage criteria. We use Epic as our EHR. I'm not sure if it has this, but I'm guessing that it does. So I just created a smart phrase. So anytime any patient that I have with who's using a CGM, I just have a .cgm Medicare phrase, and it pulls all of this into my notes so that I make sure I document it. Next slide, please. Again, the CGM companies try to make this very easy for you. So both Freestyle Libre and Dexcom have Medicare written order forms available on their websites. You can download them. And it includes the coverage criteria in here, basically. So you would check the diagnosis of diabetes, prescribed number of glucose tests per day, 4 current insulin regimens, 3 injections or more per day, and you'd sign it. And there's a list on the back of this form of DME supply companies that are working with Libre. Next slide, please. So for Dexcom, you actually can also send the prescription to the Aspen pharmacy. I called them just to make sure that they would really do this. And they said that for Medicare orders, they would then send the order to a DME distributor for fulfillment, that they contact the patient, what's going on, verify insurance, address, all of that stuff. So that's one option. Another option is to send the prescription to one of the DME distributors. That's listed right here, but it's also on their website. But an important thing to do is to let the patient know that they're going to be contacted by one of these companies so they don't think it's a scam, and so that they actually answer the phone. To expedite the process, it's helpful to go ahead and send the completed CMN and your chart notes with that required documentation and the patient's insurance information. Although if you don't send that, they will contact your office to request those documents. And the links here are to where you can get those forms. Okay, next slide, please. So, because there's a lot and not enough time today to teach everything, our UF Echo Diabetes support coaches have made some video tutorials for you all. We've shared them on Diabetes Dropbox. They're quick. They are also very resourceful. So how to do a sensor application and to set up the receiver and the smartphone. And I guess I should say these are just for Libre, Freestyle Libre 14-day system. Also how to create a professional Libre so you can see your patient's data when they come in, how to educate and train patients, and there's even a mock telemedicine training that took less than 15 minutes to do. So those are available there. But Dexcom and Libre have videos, tutorials, forms, explanations for both clinicians and the patients on their websites too. Next slide, please. So American Diabetes Association, I love their wording here. So they really say that training and support for your patients, in fact, the word that they use is robust diabetes education, training, and support are required for optimal CGM device implementation and ongoing use. So there's a few things that you should, or ideally, you would share with your patients before they begin using it. And one of them is that you can really sort of show them how to get data to make treatment decisions based on not only what their glucose is at that time, but on the trend information. What was it before? When did they last take their insulin? When are they going to eat next? What are they going to be doing? What are they planning to eat next? All of those things can be incorporated into using a CGM and improving diabetes management. Another thing to do with the Freestyle Libre, as I mentioned, you have to scan the transmitter and see your data. So you have to scan it a minimum of every 8 hours, or it's capturing the data on there'll be gaps. The dots will not be connected anymore. So you need to let them know that they have to scan it at least every 8 hours, but times that they're going to want to their glucose levels are same times that you would recommend checking blood sugar levels. So before meals, after meals, before, during activity, bedtime, etc. And really help them to understand that there's a difference between sensor glucose and blood glucose and what that means. And next slide, please. I'll get into that in a sec. It's just an example of what the patient's going to see on their reader. So they're going to see their graph. They're going to see what their glucose level is. They're going to see a trend arrow. Is my glucose going down? Is it going down fast? Is it going up fast? What's my target range? The CGM consensus group has recommended a target range of between 70 and 180, but the patient may have hypoglycemia unawareness and they want their target range to be 90 to 200. It can be customized. Next slide, please. So in terms of viewing data, there's a number of different options, and they're basically the same for both Freestyle Libre and Dexcom. There's what the patient sees, so that is either the reader or a phone app. There is what the provider is going to use to capture and view the data. Freestyle Libre calls this Libre View. Dexcom calls it Dexcom Clarity. And then for the 14-day system and for the Dexcom G6, they can invite caregivers, family members, friends to follow their data in real time. So whatever the patient is seeing on their phone app, someone else can be seeing as well. And with Dexcom, they will actually get the same alerts that the person gets. Next slide, please. So common barriers to patient engagement. So you don't want to go through all this effort and then have the patient come back and say, yeah, I worked for 2 days and it fell off and that was it. So one of the most common is that the sensor won't stay on. So there are some things that we have found very useful. Skin tack is like skin glue. So you put it on, let it get a little tacky, apply the sensor. It'll help it stay on. Another thing you can do is put these patches over. It seems to be a big business now. There's lots of options on Amazon for both Libre and Dexcom. What we have done in our clinic was we actually used grant funding, bought a bunch of this stuff on Amazon, and when we train somebody on it, we give them this, enough to get them started with a couple of sensor changes at home. Next slide, please. So another common barrier is that they think that the readings aren't accurate. So it's important expectations and let them know that this CGM, it doesn't completely replace having to use finger sticks and their blood glucose meter. There is a difference between interstitial and blood glucose readings. In fact, it's about a 10 to 15 minute delay from when the glucose is in the blood to when it reaches the interstitial fluid. This has been factory calibrated to make up for that difference. However, during times when the level is rapidly rising or falling, the sensor is not going to keep up with the meter, and that you would want to use a finger stick meter. Also, they're never going to match. I mean, they're probably never going to match. You could have a 120 on the sensor glucose and a 140 on the blood glucose, and that's considered within an acceptable range. So it's important to let them know that it's never going to be an exact match. Usually accuracy improves after the first 24 hours. There seems to be sort of a wetting period of that filament that's under the skin. But in general rule is when in doubt, get your meter out. And sometimes the receiver will let folks know this is the time to be in doubt. So the Freestyle Libre will actually show this symbol with a little blood drop. It means do a blood glucose reading. And sometimes it will show a number with no arrow, or it'll say low or high, so there's no number. That would be a time to get the meter out. Next slide, please. So coding and billing. So to place a sensor, a personal patient-provided CGM, you're going to use 95249. If you're using a professional or a clinic-provided CGM device, that is 95250. To interpret the data interpretation, it has to be on at least 72 hours of continuous CGM data from either personal or professional device, 95251. So next slide, please. I've just shared some sample documentation. So this is what we use when we do a sensor placement in our clinic. Basically, the person has diabetes, they need a glucose monitor for this reason. We put the sensor on this place, and it was starting to use the receiver, and that seems to satisfy encoding requirements. Next slide, please. And then this is for interpretation. So essentially, when it says snip the AGP image here, the reports are going to show you the LibreView or the Dexcom Clarity. They're going to show you an AGP, which is the ambulatory glucose profile. We just snip that out of the report and copy it into our note, and then just review what the data showed. Next slide. Tips for integrating it into your practice. One tip would be contact the representatives in your local representatives. They would love to come in, do a wear and share. Wearing one of these and experiencing it for yourself is probably the best way to do it, but also set some realistic expectations for your patient. You may need internal IT support. The receivers for both Libre and Dexcom require installation of some software onto your clinic's computers, so that may need IT support. And then it's helpful to have some training. Again, the reps can help you with this and how to set up your clinic account, add patients to your clinic account, helping patients or train your staff on how to help patients set up their personal accounts and upload their data. And then in viewing reports and interpreting that data, I'm happy to do a second presentation should you ever request that information. So next slide, please. Thank you again so much for having me here today, and I'm happy to answer any questions if there is time.
So I didn't see any questions in the chat right now. I think I'll pass it over to Steph Smith.
Sure thing. Thank you so much, Eleni, for sharing this key information. I think that this is great insight to think both from the diabetes perspective as well as the blood pressure perspective, and kind of giving our health centers insight into how they can implement these different programs and different insight into those options. So thank you so much for sharing this presentation. It was great. Perfect. So with that, I will pass it to our Director of Research here at Health Choice Network, Dr. Catherine Chung-Bridges, who's going to speak to us today about QI and research and the intersection of those two amazing topics. So please take it away, Dr. Chung.
Can you hear me okay?
Yes, we can, and we can see you perfectly.
Okay, great. All right, thank you so much, everyone, for this opportunity to speak with you today. My name is Catherine Chung-Bridges. I am, since October of 2020, the Director of Research here at Health Choice Network. I am a family physician by training, but research fellowship trained in with my master's in public health, specializing in epidemiology, and a strong interest in using research as a tool to help eliminate health disparities. So I'm going to be very brief. I just wanted to give a little introduction to a couple of different research concepts. And I want to give a special thank you before I get started to Dr. Nita Mohanty from the Alliance, who generously shared some of her slides with me. So some of these slides have been included today. As we go along, there will be a couple of polling questions that we will ask. And the first of those is, have you ever participated in research? And I'll ask Stephanie to help walk you through the question.
Perfectly. Thank you so much. So for this, we're going to actually take out our cell phones for this section of the polling. So for the first 3 questions, we're going to be using Poll Everywhere. So in order to participate through the polling, you will need to take out your cell phone and text QTECH, QTECH, to the phone number 22333. So once you've sent a text message to that phone number, then you will be able to participate and provide either A for yes or B for no if you have ever participated in research. And I see at least 1 response has come in so far, so that's fantastic. We'll give folks a couple more seconds to participate. Okay, so it looks like we have responses coming in. At some point, I thought it was going to be neck and neck for a second there, but it looks like a majority of folks have participated in research.
Okay, that's great to hear. That's great to hear. And yes, so we'll talk a little more about how we can even further increase participation in research among our community health center partners. So thank you for your responses. So I'll move on to the next slide, please. Okay, so really this part, I just want to show you, I think, information you already know, which is that community health centers are doing a great job of providing care to our underserved patients. So for example, even though community health centers have a higher prevalence of diabetes than the national average, so 1 in 7 patients with diabetes versus 1 in 10, yet community health centers are doing better at controlling diabetes among their patients. So 67% controlled versus 59% nationally. Next slide, please. So the big question is, what is the secret sauce? How is it that the community health centers are doing such great work? And here are a few more examples. Next slide, please. So we mentioned diabetes. So hypertension is yet another disease process where there's a greater amount of control that's happening among the community health centers than nationally. Next slide, please. There's a lower rate of low birth weight among community health center patients relative to at-risk patients nationally. Next slide, please. Greater satisfaction with care, both the hours of operation and the overall care received. That's greater among our community health center patients. Next slide, please. And these two we can move quickly. So this is that women at health centers are more likely to receive mammograms, and are more likely to receive pap smears than nationally. So again, there's something special that community health centers are doing that's superior to what's happening in the rest of the country. And the real question to ask is, what is it? What's going on? And that story needs to be told at a national level. So we really want to know how it is that community health centers are so successful in providing high quality care to patients who we know historically suffer, from disparate negative health outcomes. Next slide, please. So at this point, we're asking another polling question, similar to the last one. So the last one asked if you have been involved in research. This one is, would you be interested in participating in research going forward, especially a project that aligned with your health center QI priorities? So once again, Stephanie, are you going to walk through, or is it the same?
Yes, so if you have that chat message open within your cell phone, so that message where you sent the word QTEC, QTECH, to the phone number 22333, then if you have that chat open within your cell phone, then you can just simply put A or B within the message.
So this one is pretty overwhelming, right? So it's good to know that there's a lot of interest in participating in research studies, and it's my hope that at Health Choice Network we can help to facilitate that activity at the community health center level. So the next slide asks the question: what happens when populations we serve aren't included in research? And I'll move quickly to the next slide. So essentially, it causes us to question the applicability of findings that are in the literature to our patient population. We know that, if minorities are underrepresented in clinical trials, that's going to cause the patients themselves, as well as us as providers, to question how much these interventions are going to work in our patient population. So for example, we know that African American men are twice as likely to die from prostate cancer relative to white men. However, they represent just 4% of prostate cancer clinical trial participants. Suicide is one of the top 3 causes of death among Asian American women under 45 years of age, yet they constitute only 1% of trials for potential treatments for major depressive disorders. And the prevalence of diabetes among Mexican Americans and Puerto Ricans is more than double that of whites, but yet they represent only about 4% of diabetes trial patients. So overall, we have to do better, right? We have to figure out ways to have our patients involved in this critical research, which is really the foundation of all of the clinical care that we provide. It's the foundation of all evidence-based care. So the next question is to name one barrier. So this is an open-ended question. Can you please name a barrier to your health center's participation in research? And Stephanie, is it the same?
Yes, it is the same chat box. So if you have that already open on your cell phone, then for this specific question, you could participate in the same manner. So if you have a message that was sent to the number 22333 with the word QTEC, then you can use that same chat message to provide your response to this as well.
These are really great. So I'm seeing it looks like resources are a significant issue, resources in the way of time and staffing, but then buy-in from the patients. Sometimes we don't even want to say the word research to our patients because it can have very negative connotations depending on who we're speaking to. So I see that as an issue. I saw that somebody mentioned administrative support being an issue at the particular health center. So there are a lot of barriers to overcome, but the disconnect is there because on the one hand, we're saying that it's very critical that we develop research projects that involve our underserved communities, especially at the community health centers. But on the other hand, the very people who are best positioned to do that research are overstretched in the way of time and resources, and the patient populations are very reluctant as well. So there's a lot of work that we need to do. Okay. All right, so the next slide just talks about in general, what are the benefits of participating in research at the level of the health centers. So participating in research brings funding to the health centers. That's a major help, especially because we're talking about the barriers that exist that make it difficult to do the research. There's also increasing provider engagement and satisfaction that occurs. Many providers, are feeling on the verge of burning out and wanting to make a deeper contribution, and research can be a way to do that. And as we mentioned, in general, it's a way to better serve our community. So the next few slides are kind of an introduction to explain research at Health Choice Network. What are some of the projects that we're working on? And there's one particular project called Pitch to the Panel that I wanted to introduce today. And you'll hear more about it as we go along in future meetings, but I just wanted to introduce that concept. But first of all, some of the research projects that are going on at Health Choice Network include a lot of work around COVID-19, of course. There's a Florida SEAL project, which is an NIH-funded intervention to look at misperceptions among our community health center patients about COVID-19 and vaccination. There's an overall project in combination with University of Miami to increase research capacity at the community health centers. And the dental research is really taking off at Health Choice Network community health centers, as we are developing projects that look at the intersection between dental findings and the medical outcomes. So lots of very interesting work going on. We can go to the next slide, please. Key collaborators and partners include the Alliance Chicago, University of Miami, Microsoft, and DentaQuest. Next slide, please. So there are lots of different ways to answer particular research questions, and at Health Choice Network, we are working on each of these different methodologies. There's secondary data analysis, where you have a particular health outcome that you're looking at either cross-sectionally or over time, and looking at the risk factors and the association between those risk factors and your health outcomes. There's also qualitative research going on at the community health center. So focus groups, interviews, that the goal of those is to go deeper and to understand, even beyond what the numbers are showing, what the attitudes and beliefs are among our patients, providers, staff, et cetera. So at this point, I just want to take this last slide to really show you and discuss with you what Pitch to the Panel is. So Pitch to the Panel is a project that we want to initiate here at Health Choice Network. again, believing that research should be driven by the community health centers, by the patients, by the providers, and by the staff at the community health centers. So by research ideas coming from the community health centers, research is going to be more relevant in the questions that are being asked, and the results are going to be more meaningful to our patient populations. So the idea of pitch to the panel is that if you have a research idea that you'd like to develop, you can let us know. And what we will do is we will work with you to develop that idea. And what we'll work with you to do is to develop your study background, to design your methodology, to figure out, is this question better answered through a quantitative methodology like a data analysis? Would it be better to do some focus groups and interviews to understand? Should we do a survey? There are lots of different ways that we can answer a particular research question. We also help, of course, to operationalize your outcome. What are we really wanting to measure here? Is it the A1C, or is there some other outcome measure we should be looking at? And then what we'll do is, this project is in collaboration with University of Miami, and the goal would be to identify researchers at University of Miami who would be interested in partnering with you to complete the particular research project. So essentially what we would do is find out who would be interested in working with you on the project. And then in May of 2021, we'll have a session, which is the pitch to the panel session, where we'll have the University of Miami researchers on a panel, and you would be able to present your project, and at that day, at that date and time, have a true match with a University of Miami researcher to then move forward with your research project. Now, what does that really mean as far as developing the project? So depending on the resources that would be needed, there could be a grant application that comes from this, or the project can actually be done, especially if it's a secondary data analysis, or it involves doing focus groups and the resource requirement is not that great. But that's really the process that we want to undergo in the next few months. So at this point, we're looking to see who is interested in possibly being involved in a pitch to the panel project. The next polling question is really, would you like more information on pitch to the panel? So this answer will be recorded so that we'll know, who is interested, and I will be following up with you to discuss more about it. So.
Sure thing. So thank you so much, Dr. Chung. So with that, the poll question for this specific question should be on your screen. So to participate in answering the question, would you like more information on pitch to the panel? Please take a look at your screen where you have the go to webinar space up. And from there, you'll be able to see the quick poll on your screen. And from there, you can be able to select the options, either yes, no, or unsure. So we're going to give folks just a couple more seconds to get the question answered for us today before we close out for this section of the agenda. So we'll give everyone just a couple more minutes to respond.
All right. Excellent. So looks like there are some folks that I will be reaching out to, and we'll be able to continue the discussion. And I thank you for the opportunity to speak with you today. And I really look forward to getting to know you better in the future. Thanks.
Fantastic. Thank you so much, Dr. Chung, for sharing your insights on this. And we'll make sure to get you connected with everyone that's interested and wants to learn more about Pitch to the Panel. So with that, we're going to now pass it to Harut Kasai, who's going to talk to us a little bit today about the UDS specification review and changes from 2020, as well as looking at some of the changes within 2021. So Harut, the floor is yours. Thank you.
Okay. All right. Good afternoon, everyone. So just a few words on UDS. I know we just have a little bit of time, so I'm going to move pretty quickly. So the first slide that I have for you, basically, I just wanted you, a lot of you want to know what the national benchmarks for these various UDS reports are. So what I've provided here is in that second column, it shows you the national average. This is for community health centers, and this is based on your 2019 UDS reports. Now, HRSA always gives us the updated national averages in the summer. So for the UDS reports that we just submitted, we will get those national averages come this summer. So these are based on 2019. So that's first column, and you will notice that the last three items, which are the new measures that were added to UDS this year, we don't have a national average yet. In the next column, what I also put in here for you is the new Healthy People 2030 goals. And I've left the Healthy People 2020 goals on that last column so that you can see what the comparison is. So for pediatric immunization, I did not see a Healthy People 2030 goal for that entire panel of pediatric immunizations by age 2. So the 2020 goal was 80%. We don't have one for 2030. For cervical cancer, that Healthy People goal has actually gone down. You recall it used to be 93% was the target, and now it's gone down to 84.3. So still pretty high, but a lot more achievable. On the other hand, the ones for colorectal cancer and diabetes control have gone up. Colorectal cancer is now 74.4, as you can see, and diabetes control has really gone up. If you remember, this is a reverse measure. In other words, we want to get this percentage as low as possible because it's looking at uncontrolled diabetes. So now that has gone down to 11.6. So that's a little, quite a bit more challenging than the 16.1. Hypertension, blood pressure control is a little bit lower, just a tad. It used to be 61.2, now is 60.8. Did not find a Healthy People 2030 goal for the low birth weight measure. But the access to prenatal care, that goal has gone up a little bit to 80.5%. I did see a 2030 goal for IVD therapy, and that's 69.7, which is lower than the national average. So I think we should be able to be okay with that one. And then for HIV Linkage to Care, there is a Healthy People 2030 goal of 95%, as with the new HIV screening measure. And for breast cancer screening, the Healthy People 2030 goal is 77.1. And that's actually lower than Healthy People 2020 goal. But 2020 was the first year that we actually had to do that. So I just wanted to just provide you this so that you know what the, kind of the benchmarks out there are. All right, so with the next slide, what I wanted to do is just quickly review the 3 UDS clinical measures that were added in 2020, just to make sure that we're all very, very clear on what they're asking for, especially this first one, depression remission at 12 months. I think there has been some confusion. So basically what this measure is looking at is percentage of patients 12 to 17 years of age, so adolescent patients, and adult patients 18 years of age or older with a diagnosis of major depression or dysthymia who reached remission 10 to 14 months after they were diagnosed. That CMS 159 V8 is it's actually a hyperlink to the ECQM. You can click on that and we'll take you to the ECQM page. So the denominator for this is patients age 12 and older with a diagnosis of major depression or dysthymia and an initial PHQ-9 or a PHQ-9 modified for adolescents score that is greater than 9 during that index event. Patients may be screened using PHQ-9 and PHQ-9M up to 7 days prior to the office visit. For purposes of UDS, that index event for our current reporting year should have occurred between November 1st, 2019 through October 31st, 2020. And they should have also had at least one medical visit during the measurement period. Okay. And then the numerator is looking at patients who have achieved remission, and this will be based on a PHQ-9 or PHQ-9 modified score of less than 5. Okay. Now, there are some exceptions. So if you look at the next slide, denominator exclusions include patients with a diagnosis of bipolar disorder, personality disorder, schizophrenia, psychotic disorder, or pervasive developmental disorder. Obviously, patients who have died, patients who received hospice or palliative care services, and patients who were permanent nursing home residents. There are no numerator exclusions or exceptions. So one of the things that we need to be clear about is, although the PHQ-9 is not the only screening tool approved for the screening measure, for this particular measure, the depression remission, it must be evaluated using a PHQ-9, or in the case of adolescents, a PHQ-9 modified screening tool. Okay, so we just want to make sure that we're all clear. There was a little bit of confusion with some people, using the PHQ-9 for people who are already diagnosed with depression. So this really is, once a person has been diagnosed, then this is for purposes of assessing whether whatever treatment plan is put into place for the patient is working, by really, taking a look at them again 12 months out and seeing if remission was achieved. Okay. All right, next slide. The other two are more straightforward. The HIV screening measure, again, that's a hyperlink to the ECQM. This is looking at percentage of patients age 15 to 65 who were tested for HIV at any time. Once, it's looking for them to have been tested once. The denominator is patients 15 to 65 at the start of the measurement period and had at least one medical visit. And the numerator is patients with documentation of an HIV test performed on or after their 15th birthday and before their 66th birthday. The only denominator exclusion is a patient diagnosed with HIV prior to the start of the measurement period. And there are no numerator exclusions. The key here is that this HIV test has to be documented. A patient telling you that they've previously had an HIV test is not enough for this measure. You actually have to have a record of the test. If they've had it somewhere else, communication with that facility with proof that they've had the test, or you just do the test again. So patient self-attestation or self-report does not meet the measurement requirement. Okay, next slide. So the third measure that was added in 2020 was the breast cancer screening, and this is looking at percentage of women 50 to 74 years who had a mammogram to screen for breast cancer in the 27 months prior to the end of the measurement period. The denominator is women 51 to 73 years. Now, this might sound a little bit confusing. It's the way that, the measure only evaluates whether tests were performed after a woman turned 50. So by the time your measurement year finishes, the youngest age of people in the denominator is actually going to be 51. And that's why you see that little discrepancy or difference in that number. For the numerator, women with one or more mammograms during the 27 months prior to the end of the measurement period is what makes them fall into that numerator. There are some exclusions. Women with a bilateral mastectomy or women with a right and a left unilateral mastectomy will be excluded. Patients who are in hospice care during the measurement period, or patients age 66 or older who are living in an institution for greater than 90 days, and patients age 66 and older with advanced illness and frailty. And there will be codes for those particular exclusions. There are no exceptions for the enumerator. Okay, next slide. So the other thing that I wanted to just do is briefly give you an update on approved UDS changes for 2021. These were published by HRSA sometime last year. I forget the exact date, but there is a PAL that was out with approved changes for 2021. There are not going to be any new clinical measures that are being added to UDS Table 6B and 7. But they are going to be aligning with ECQMs. That they always do that. So the measures that are listed are being updated to the most recent version. Usually these are very, very minor tweaks. I did not have a chance to look at all of them. I did go through the one for immunization just to kind of get a sense of what the changes were. A lot of it was in, language changes, changes in updating their resources and things like that. But we will be taking a deeper dive to see if there's any substantial change that you need to be aware of, and provide you with that information in subsequent meetings. The other changes to UDS for 2021 are around COVID. If you go to the next slide. So there were additional information that was added to Table 6A in 2020, and this included, procedure codes, HCPCS codes, ICD-10 codes that were added to allow for reporting of instances in testing and diagnosis of COVID. These will also appear in the 2021 reporting, and if any new codes are added, they will be also included in 2021. The other change is also additional lines in tables 9D and 9E. This is for the financial pieces. As you know, HRSA awarded supplemental funding through various legislation this year to support health centers, last year, and continue to do so this year. So those will be included still in the 2021 reporting, and any new funding source will also have additional lines added for 2021. In the Appendix E, there is a question on vaccinations that we had to fill out in 2020. This will also be included, obviously, in 2021. So these are basically the changes that were published in the PAL that came out sometime late last year. Okay, so really quickly now, we're almost out of time. So I do want to thank you. Just want to remind you, next month is colorectal cancer screening month. So hopefully we wanted to have a discussion. We don't have time, but I just want to really encourage all of you to plan something for that month. It is important that we get our patients tested. And with that, I am going to turn it over to Stephanie, unless anybody has questions.
I did not see any questions in the chat, so I'll pass it back over to Stephanie.
All right, thank you.
Sure thing. So we do have a few updates in relation to strategic planning opportunities that we identified through some of the polling we did last month. And I'm looking at the time, so we do have about 2 minutes left, actually. So I'm actually going to pass it to Stephanie Martinez, who will talk a little bit more about the QTEC questionnaire.
Thank you, Steph. We will share these slides with everyone. So that's actually, I think, on the panel piece of your handout section for the webinar. I do want to plug one more time our QTEC annual questionnaire. Thank you to everyone who has filled out the questionnaire. We do have 30 participating health centers in our grant, and it's very helpful for me to get a pulse on where your health center's at. Through this questionnaire, it does take some time. I will re-email it to the health centers you see on the screen here, but I am still pending some health centers, so I've listed you here on the screen. I would very much appreciate it if you could just take the time to fill out the questionnaire. I'll be reaching out to you all individually one more time. Other than that, if you have any questions, feel free to email me. And thank you. Steph, I'll pass it back to you.
Thank you. So then I think the last slide we have here is just a reference to next month's meeting. So we're really excited to have the Qtec team join us for the March meeting. So we're hoping to start a learning collaborative with that partnership. So we're able to dive in a little bit deeper on a topic related to patient engagement. So electronic patient engagement and how we can learn together in better ways to support those efforts at your health center. So more to come on that. As Stephanie mentioned, we do record this meeting, so the recording as well as any sort of materials that were shared during this afternoon's meeting will be shared to you following this meeting together with us all. So thank you so much for taking the time to join us for the monthly QTECH committee meeting. So thank you and have a great day.